very uniform, desirable dose for this. So I will talk a little bit more about the advantage of that. Of course, the benefits is significant. For example, the X-rays, due to the low dose bus, the risk of a secondary cancer is 30%. Compared with the proton beam treatment, the low dose only generates 4% for a craniospinal type of treatment. And for pediatric patients, they are very important. So I already mentioned the older technology called the scattered beam. The scattered beam using hardware to produce a beam, which is not adjustable. The spread out black peak cannot adjustable at the different location of the tumor. Compared with the pencil beam scanning, you can adjust the thickness of the penetration at each location. It can generate much more conformal beam. So this is an unwanted dose. If your tumor is not uniform and the red area is overtreated using a passively scattered beam. So this is another example showing you why the pencil beam is dominating. This is the three-field technique using a double scattered beam. You can see the conformality is much less than on the right side. You use a two-field pencil beam scanning, you can generate much better dose distribution with the pencil beam scanning. This is one of the reasons, since 2014, the pencil beam scanning technology is dominating. It's already exceeded the number of treatment rooms using a double passively scattered beam. In fact, double scattered beam started going down because a lot of centers are upgrading those rooms into a pencil beam scanning. So that's definitely one of the key development in a modern therapy. So I'll use this slides from Varian. This is one of the beams in San Diego where I work with. So it has a very modern proton therapy system. For example, 360-degree gantry. The 360-degree gantry is very convenient. You can treat from different angles. If you have a half beam rotation, for the reason of cutting the cost, you need to rotate the couch. And this is a robotic couch. You can rotate patient to another side, but it takes time, and also you have to imaging them. So you have an X-ray, cone beam CT, and a robotic couch. The robotic couch is very versatile. You can do a lot of things with it, and very small as well. I just want to show you, this is myself doing the commissioning. We're trying to simulate a vertex field, the beam coming from the head, the top of your head. And you can see it fit in this gantry very nicely. So this is a very nice robotic small couch you have. Another thing is the integration. You need to use software in order to control the system. So the Varian system has a nice interface, very similar to the true beam. So essentially, the therapists who operate the system has very minimum training. They can learn the imaging is on the right side, control system is on the left side. So lots of design are similar. So instead of learn another control system, they use a very similar design. So that's one of the integration. Another thing people need to realize is the proton system is a system. So it has multiple components in order to run a proton therapy center. For example, there is a treatment delivery software, a controlled hardware, whether it's Varian or it's Varian or IBA. This is the hardware accelerator that you need to use the software to interface to control them. And also the software need to communicate with the oncology information system. And this system store all the patient information, treatment plan, etc. And of course, it will communicate with the treatment planning system. So also the exchange of information are critical. I was working at MD Anderson Cancer Center in Houston. They have a Hitachi system, has a mosaic in the different oncology information system. So the different version has creating lots of compatibility. So hopefully, there will be a Varian system is one system, so you don't have those exchange. You don't need to export treatment plans in order to deliver a treatment plan in the hardware. So those are very important. And regarding the treatment room, you have a multi-room configuration versus single room. The multiple room is that you can share the same cyclotron. because beam can be shared among the different rooms, so the cost is much lower. The treatment time is very small. Usually the beam on time is on the order of 1 minute or less. So and treatment time overall is about 20 minutes, maybe 70 minutes overall. But you can imagine most of the time is spent with setting up the patient. So that's why you can have one accelerator to support multiple treatment rooms. However, if you are interested in cost cutting and also you want to be a part of the photon therapy treatment system, single room is a very nice solution. You can completely integrate your photon treatment system and just be one of the modality of radiation therapy. So the cost is lower. So I mentioned, this is a physics part of it. So if you have a pencil beam, things will be much easier. What you need to worry about is the dose, attenuation in the beam. It's an integrated depth dose you need to measure. And also you need to measure the beam profile. That's a characteristic of the pencil beam. You also need to know the relative output factor of different energies. And also you need to know if you have a range shifter to treat a superficial target. Those are the things you need to measure, And the commissioning is much quicker. Usually it's about 2 or 3 weeks, in the modern treatment planning system. So it's much quicker than the traditional double scatter system. So there are lots of equipment, need to be purchased. But I have to say, once we have a pencil beam scanning, all the devices come down to a few choices. So the selection of the pencil beam measurement device becomes simpler. You need a parallel plate chamber, water tank, and also some fluence measurement device, digital device that can give you the best dosimetry. So treatment planning, I'm going back to a little bit of treatment planning. I mentioned about robustness or the uncertainties. So newer treatment planning system has to deal with uncertainties. So uncertainty means, the robustness means you need to be able to evaluate what happens if there is a setup error or there is a range uncertainty. What the treatment plan will look like. Even better, you can build in the robustness as an optimization procedure. For example, you can optimize the uncertainties inside the treatment planning system with the goal to minimize their impact. So I don't want to say the different uncertainties. Most of those red is leading to what they call range uncertainty. So essentially, range uncertainty is the biggest challenge, difference between photon therapy. So hopefully, the optimization algorithm can do minimize the risk. So this is just one example showing if you don't anticipate the range uncertainty, you could put in the beam directly sparing the spinal cord, and unfortunately, if there is a range uncertainty, the dose may be hitting the spinal cord. So the selection of a beam angle and also understanding the impact of uncertainty are quite important. So there is a different treatment technique. What I want to emphasize, in modern days, we want to use multi-field optimization. This is similar to MRT optimization. You want to use multiple beams to give you the best treatment plan. However, in order to do that, we have to build in the robustness. So I want to give you just a quick formula. There's an uncertainty built in the equation. I don't want to discuss it, and the end result is like this. So if you have a Bragg peak or the proton beam, and there's a body inside the target, so how do you minimize the impact of the range uncertainty? So if you don't consider range uncertainty, there's a potential errors. For example, the beam is not the same. You will see there is a big dip. I'm sorry. You will see there is a big dip in this target due to range uncertainty. So what you can do is you can create a gradient inside this beam. Similarly, you can create another gradient. So you have a sloped beam. If you have a sloped beam, it more resists the uncertainties. So the variation will be smaller than this way. So that's kind of a simple way to explain robustness optimization. So I can show you if you have this capability, you can generate a very good plan, which is coming. So just an illustration, this is a the chordoma case, if you have an old way to treat it, I don't know, missing some of the slides. So if you generate a smooth gradient among these three fields, you can generate a very robust treatment plan. Even the spinal cord is right here. So you can treat this type of a disease with a robustness. So Varian has made this available. It's an inside treatment planning system. It's called robustness optimization. You can specify the range of uncertainties, so you can do the optimization for it. The net effect is the variation is going to be reduced. This is the figure showing you the DVH band. So without the robustness optimization, it's a bigger variation. With robustness variation, the variation will be smaller. So that's one of the ideas. So I mentioned you could use it for some of the typical treatment I just told you. The junction shift in the craniospinal treatment, the junction shift is very important. So you can design a slope gradient between the cranial field and the spine field, and you can generate very robust treatment plan and for patient treatment. And this is a general idea. If you have an adult CNS case, you design a cranial field with this junction field. You have another spine field, another spine field. If you combine them together, it's a very robust plan, a beautiful plan for those. You can also treat breast cancer. Remember, breast cancer, challenge, we usually use parallel opposed beam, but there are lots of heterogeneities. Fibrosis, there are lots of things caused by photon beam because of the non-uniformity of the geometry and the field matching. So with the proton beam, you actually can even use one treatment field. And the beam angle is not a tangential field. It's an unfast field, the beam directly towards this direction. It's actually minimize the motion effect. If the patient breathing, the beam is going to go with it. The range will not change due to a patient breathing. So this is one of the ideas. If you have a bilateral breast cancer, as shown here, this is the proton plan. It really can spare the lung dose. With this bilateral breast cancer, it's very difficult to treat with X-rays because the dose will be too high for the heart and for the lung. So those are unique advantage of breast treatment. So you can also use a more conformal treatment for breast, including some of the implants. For example, you can use a two-field treatment, multiple field optimization technique. So one field treat the entire superclad field and the breast chest wall, and another field is on lateral direction and only treat the lateral direction. And they have a gradient matching along this. Automatically the robustness optimization create a gradient matching. So if you combine them, it becomes a uniform field. So these are a very typical application of robustness optimization. You can use the same method to treat a patient with an implant. If you have a metal artifact implant, so those are very difficult to treat with a proton in the old days because of artifacts. The tissue density varies, you don't know about that. So what you do for this case, you can design a treatment plan, use a field-specific target. So you can design a treatment plan. For example, you need to contour this and show where is the implant location and break the target into two parts. One part is relative to this anterior beam. You have a target that will not treat through the metal, so it will be in front of the metal. And similarly, the lateral beam will treat only the lateral side of the target, not going through this metal. So if you combine these two treatments, it becomes a uniform treatment. So dose inside the implant is lower, but there's no tumor in there, so that's okay. So this is one way to do that. You can see this is a two field, they nicely combined together. So the composite dose is a robust plan. So those called a beam-specific method. You can design beautiful plans like this. So I want to just talk to you a little bit more about conformality. So we talk about low dose conformality. The proton can spare the low dose. It can also spare the high dose region. For example, This is a isodose distribution of a head and neck plan. If you're showing the 45 gray, so this is the area of a 45 gray treated with photon. And you can compare with a proton with a 3-field treatment technique. The proton 45 gray is much conformal to the target than the X-ray. So even on the high, remember 45 gray is high dose. It can cause a lot of normal tissue damage than low dose. So the proton is actually generated a higher dose conformality for the high dose region. This is one example. This is another example at different color. So this is the 45 gray of X-ray therapy. And compare with the X-ray therapy for the 45 gray generated by the proton beam. So you can see the conformality in the high dose region. So with the pencil beam scanning, you're really taking advantage both the low dose Varian and also the high dose Varian. So that's very important to know. Yeah. There are also special delivery technique. For example, if you treat this minimize the hippocampus dose, you can design a beam avoiding the hippocampus for two field. The result is you minimize the effect of the hippocampus dose. Depends on the target. And I mentioned, there's a very complicated treatment technique for retroperitoneal cancer. You can design a field-specific PDV and completely sparing the tissues in the middle. So compared with a photon MRT, you can't do it. The reason is X-ray penetrate too much, so you can't protect the middle portion inside this target. So those are good applications of a proton therapy. So larger tumor is another area. For liver cancer, if the target is very large, it's actually very toxic for the patient. With a proton beam, you can generate much better conformal dose to spare the normal tissue. There is actually a study showing how big size of the liver cancer you can benefit the proton therapy. So the study showing if the tumor size, liver cancer size greater than 7 cm, the proton therapy started taking advantage compared with the photon therapy. So those things are gradually getting into the field. So knowledge-based planning, I'm a little bit short, I'm going to go quick. So the automatic treatment planning is another feature. Varian was designed that using machine learning. And they can also apply to proton therapy that can greatly reduce the learning curve for proton planning. So the basic idea is the computer can automatically estimate what's the desirable DVH. Then the treatment planning parameter will be automatically placed into the system, and the system will automatically design a treatment plan. So how they're doing that, just the idea. So if you look at the beam, there is an outfield beam. The beam never reach, essentially. There is also overall leakage, and this is an X-ray therapy. And there is also an infield where the beam going through, but not reaching the target. And also there is a target region. So all these three fields has a different meaning. So if you look at where the machine learning is started, is this infield region. Because this is infield region where the penumbral effect is going to be depends on the beam geometry and the patient specific. So there use machine learning and predict inside this penumbral region what's the behavior relative to the geometry. So you can model them, it automatically predict DVH for you. So you can use the same concept for the protons. For outfield, there's no outfield. There's no dose outside of the proton beam. So infield is similarly, you have a similar infield. And the target overlap is going to be the same. So you actually can use the same technique, applied to a proton therapy. Just the infield is different. So of course, you need to have many patients to do that. So I was involved, in the collaboration work with a Netherlands group. There was a 50 patients head and neck patient treatment. So we designed a 3-field treatment technique, and we applied this automatic planning, knowledge-based planning, and compared with the 3 different centers. We are one of the centers. So the results showing, the automatic planning, which is shown in this column, it generates very reasonable dose, compared with the left side of the institution-produced manual treatment plan. In overall, their centers match very well. Essentially, it's just matched with the clinical cases to use. And the other centers, the knowledge-based planning actually doing better. This is for a new center just started. So those things are very useful for a new proton center, and people has not gained experience enough. So automatic planning is definitely one of the area. So I just don't want to go into detail. It's showing you the knowledge planning actually produce a lower dose on some of the structures, because the automatic planning automatically take care of the beam overlap region and reduce the planning objective. So it was just the last slide is showing you the summary of a modern proton therapy. First of all, everywhere is adopting this pencil beam scanning. The pencil beam scanning did not use any hardware, so it's all software control. So as you can imagine, the software application, like treatment planning system, it's become more intelligent, so you can deliver much more flexible beam, improve the quality, and also improve the workflow. Another thing is there is definitely increase in the in-room imaging, with this modern system. Home beam, CT, robotic, etc. is all available in modern proton system. Just a side note, for some of the carbon center, they're actually behind in terms of imaging. The older system, they have a hard time to catch up with modern treatment. And also the compact system I mentioned, it started doing that. There are lots of design to reduce the cost. For example, even the integrated system itself, to reduce the training, it will be one of the components to minimize the design. For Varian, I summarized the field size is a key factor. Remember the breast treatment? If you have a larger treatment field, you only use one field you can treat. So it's much more efficient. Even for their compact systems, they have the larger field size, 25 cm by 25 cm. Of course, 360-degree gantry angle. I mentioned there are fewer imaging, fewer treatment steps, so it's much more efficient to go through the patient treatment. Integrated solution, as well as I did not mention beam matching. I think in the Russian group shown the beam can be matched, so you don't need to commission in multiple rooms. Just one beam you say, so it's very efficient in terms of the operation. So with that, thank you very much.
Уважаемые коллеги, вопросы?
С какой мощностью дозы, во-первых, вы работаете, дозы, и во-вторых, как часто надо проверять на линейных ускорителей обычных, мы каждое утро проверяем его, да? Как часто надо проверять стабильность протонного луча?
Yes, we have a same quality assurance program for proton beam as well. In the morning, we check the imaging. We also check the range. We check the output. So there are lots of things that are very similar to a proton, the photon therapy QA. We do check. The dose rate is not checked. However, the dose rate in normal situation is not vary too much. So the typical dose rate for conventional proton treatment is about 1 gray per second. It's actually instantaneous dose rate is very high. However, the pencil beam is going to scan through the entire treatment field. So the entire treatment field time is still slower.
Мощность дозы 1 грей на строчку в секунду. То есть это 2 грея на литр. Да. So it's about 2 grays per liter.
Yeah, it's about 1 gray per second.